Neesha has a background in primary and community nursing in South London. She's worked in consultancy and held a number of specialist nursing roles over the past 15 years. She's worked in higher education since 2014 and in 2017 was made a Senior Teaching Fellow of Higher Education. Neesha has developed a national and international reputation, becoming a member of the National Wound Care Strategy Programme. Neesha's research relates to diversity and inclusion in clinical practice. Neesha's session will provide an overview of her research pertinent to dark skin tones, the findings, conclusions, and application of these to clinical practice.
Hello, and welcome to the presentation into my research around people with dark skin and pressure ulcers. So my focus for this presentation is around my own research that I carried out as part of my doctoral research and the successful completion of my PhD. So my focus was around addressing skin tone bias in wound care, assessing signs and symptoms in people with dark skin tone, and what the research actually tells us. So just to put a bit of context around what my research focused on and why it's so important. So in the UK, all higher education institutions have a statutory duty under the Race Relations Act and Equality Act to have individual mission statements and policies addressing equality, diversity and inclusion. So we need to be considering race and ethnicity as part of our education programme and delivery strategy. And furthermore, as nurses, we also hold an NMC responsibility towards our patients to ensure that we deliver equitable care, that we understand the factors that may lead to inequalities in health outcomes. So as part of that, how does it all sit in with our health inequities, and what does this all mean? So we need to highlight that more than 1,300 new pressure ulcers occur monthly in the UK. And in 2020, there were 2 independent reports that were published that focused on inequitable outcomes for Black, Asian and minority ethnic groups, not because of their own self-inflicted health inequities, but because of systems and processes. So this related to COVID-19 and also to the Membrace study around mothers from Black and Asian backgrounds who were more likely to die at childbirth and close after childbirth. So it's important to highlight that actually the health inequities are embedded within the structure. And we also need to recognise that dark skin tones rarely show the blanching response, and erythema may be hard to detect, which Jackie spoke about previously. In general, health inequities are well documented. We do know that there are health inequities, but around skin tone diversity, this is different. This hasn't really been focused on before, and my study was the first to ever acknowledge around pressure ulcers and dark skin tones in relation to nurse education and how it was being delivered in the classroom to pre-reg student nurses. So often we've used this image, react to red, and can you acknowledge the issue there, that if we're having a reliance on looking for redness, that actually do we miss? Are we narrowing down our future clinicians' views? As we all know about BENA, novice to expert, that actually when we set out as a student nurse, that we often absorb the information and don't question the information initially, but we do develop further. And therefore, if we have images like the react to red, are we then imposing a restriction to the views that we're looking at? So what do we need and how do we describe skin tone? So again, Jackie spoke about ethnicity and that we shouldn't be using ethnicity as a proxy to skin tone and skin colour. It's not the same. They are 2 different things, as some people who define themselves as Black may not present with dark skin. So we need to acknowledge that. And we should not be comparing white, as this implies that white is the norm. So we shouldn't be using terms like non-white, because actually that we're then saying that white is the normal and non-white is everything but normal. So we need to be aware of the language that we're using and empowering our patients and students to use the right language. So now going specifically to my research and the study that I did, So I did a collective case study to critically examine the teaching addressing pressure ulcer identification in people with dark skin tones. So my focus was around pressure ulcers in the classroom. And as my introduction, my background is district nursing and community nursing, and wound care is one of the passions of mine. And that's how I sort of got involved within this research. And because of my own personal background and also interest in locality and areas of working, I was interested in people with dark skin tones. So the aim of the study was to look at educational preparation of registered nurses, so students in the classroom. And I acknowledge that students learn just as much in practice out with nurses, but actually they also have a large component in the classroom, and we often set the scene for students, prepping them before they go out into practice to be able to deliver care. So I wanted to identify what was being taught as a fundamental of care around pressure ulcers. So initially I needed to find out the language about a literature search. I needed to understand what the language was being used within the writing, within the terminology. And it was clear that internationally, pressure injury was the term that was being used. So we have the National Pressure Injury Advisory Panel, which is in the US. So I had to include the term pressure injury. In the UK and Europe, we use pressure ulcer. And again, Pan-Pacific, they're using the term pressure injury. So I needed to capture an international audience, really, in the data that was there, because it was impossible to find anything that was UK based, that was research focused on pressure ulcers. And I needed to acknowledge that some of the papers might have been older, so I needed to keep the term bedsore, even though we've moved away from that language. Then it wasn't only the issue around pressure ulcers and what's the right language to use, but also the language that we use around skin tone. So in the US, the term race is used. That's mostly because of census collection data, that's how it's collected. And ethnicity in the UK has historically been used as a proxy to skin colour, where we collect data as part of statistics around ethnicity. I also use skin tone and skin colour, as I acknowledge that there's been a change in language. However, when I initially started this literature search back in 2017, there were very few papers that talked about skin tone. So what did I find when I looked at the literature, which was revised again last year? That the data and the research is around people with dark skin is under-researched. The studies that were done were poor methodological quality, and there were only a limited number of contemporary studies. And more often, they were based on large data sets that were collected as part of quality assurance. So looking at care home data, and the data that was collected from there. So what I needed to find out was that obviously there wasn't a lot of research, that it wasn't great research that was being delivered and carried out. And I wanted to therefore know, so what were students being taught in the classroom? How did they know what was the right thing to do if the information wasn't out there? So I then went off to do a sequential mixed method collected case study. So what does this all mean? So I went to 5 different universities in England to collect data from pre-reg student nurses to find out what they had experienced in the classroom. But before that, I actually did a documentary analysis. So I looked at what was being taught in the classroom as a hard copy. But we all know that if we're preparing notes for presentations, they're not exactly the same. So I needed to observe that teaching as well. So not only did I look at the documentation, I also observed the teaching. And as part of that, I developed a diversity observation teaching tool where the data could be collected to identify what was being taught in the classroom and was it inclusive. Following the quantitative phase of the data collection, I then did carried out interviews with nurse educators delivering education. So they were delivering education based on pressure ulcers, and also did focus groups with the students. And the focus groups were third-year student nurses. Even though the teaching material was based on first year teaching, the focus groups was actually around third year because, like I previously mentioned, I recognise that students have a learning journey and it's all not based in the classroom, and that their experience can vary. And I wanted to pick that up as to what was being taught in the classroom. So what did I find with regards to the quantitative findings? So it was clear that skin tone diversity was very superficial and tokenistic in nature. And I needed to question, was it actually because I'd provided a participant information sheet indicating what I was delivering and questioning about? Was that the reason that some of the information was actually included, as it was so superficial? And by being superficial and tokenistic in nature, were nurse educators actually perpetuating colour blindness? Were nurse educators actually treating everyone the same, which isn't the right way and the right process to go ahead? So we actually needed to focus on the curriculum statements and highlight that actually they didn't match what the universities were indicating as curriculum statements, that the content in the classroom varied from what was expected to be included. So just to give you a bit more context about the quantitative results, there you can see the 5 cases. I've included the material around the images because the visual representation of people across the skin tone continuum, one of the most measurable ways is by looking at images. And you can see there at the top in the dark color is the people with dark skin tones, and actually how few people with dark skin tones was included in the image categorization. So what did the qualitative findings suggest? The qualitative findings actually suggested that there was a dominance of whiteness. So the qualitative findings came from the student nurses and nurse educators, and they reported that they felt there was a dominance of whiteness in the teaching, and that was the focus when it came to pressure ulcers and undergraduate nurse education. That there was an impact because of this dominance of whiteness, that actually the impact on the student and in practice, and that the role of external input, so guest speakers who came in, did focus on whiteness, and resources were focused on whiteness. And the last but not least was that they all made suggestions for change because they felt that something needed to be done in the classroom. So it was all well and good to do the research, but what did I find? What does this mean to people in practice in nurse education? So undergraduate nurse education must adequately include comprehensive information to address health inequities. Nurse educators need to be, and to use that phrase, brave enough to talk about skin tone diversity, because within the study, some nurse educators described that they actually felt that they couldn't talk about skin tone diversity because it was so difficult to talk about, that they actually avoided the topic. And students talked about skin tone diversity and dark skin tones in relation, and compared it to death and dying, that it was as difficult to talk about skin tone diversity as it was to talk about death and dying, which is a key point that needs to be highlighted. So the current study found that the limited research concerning pressure ulcer and skin tone diversity, educators were overly cautious of political correctness and topic sensitivity, and it was therefore brushed over. That the study demonstrated that education was one-dimensional, predominantly framed through a white lens. So students with darker skin tones, who define themselves as having a darker skin tone, explained that they didn't feel their nurse educator understood, and that it wasn't the place to ask the question, and that actually they thought about a question around dark skin tone but didn't ask it. So the recommendations is to firstly recognise that systemic racism is there, and that it does cause an issue in nurse education, because we historically have always been led by white education and the focus on whiteness. And secondly, we need to educate senior leaders that we need to be talking about skin tone diversity by a way to eradicate racism, by actually saying that larger policies don't necessarily indicate inclusion and diversity when we're delivering material in the classroom. And what I need to say is if we don't see it, we won't respond to it. And that's what has historically been taught, is that if we're relying on red lists, if we're relying on a change in skin colour, will we actually do anything about it? Our assessment tools have historically included discoloration, redness. They are changing, but if we don't see it, do we need to be considering actually, if we're doing an assessment, is it equitable for our patient with dark skin tone? Is it recognising that they are more at risk of pressure ulcer damage? So what can you do about it? What can we do about it? We need to acknowledge that skin tone diversity exists and that we have a role to play in equity, that it's all of our responsibility. And just to take from this presentation really is about self-reflection. Are you colourblind? Do you try to treat everyone the same? Because actually we shouldn't be treating everyone the same. Everyone has their own skin colour, and therefore indications and complications can appear differently, and we need to recognise that. So avoid the statements around, I treat everyone the same, I don't see colour, because actually we need to. So one of my last statements is, dare we say it? Dare we say that our healthcare system has been set up to emphasise health inequities and racism, and we need to make a change. And you are the people to make that change. So if you do want to look at more of my work and my written pieces of work, there are some publications there. And obviously it links to the best practice statement to give you some guidelines. Mind the Gap, which is a good resource to acknowledge variation in presentation of skin colour. And there are my references. Thank you.